We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, APIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
So we have another interesting discussion happening next with Dr. Diana Cervantes, here with us to discuss state of infection prevention and control in non-acute care U.S. settings, the 2020 APIC survey. So Dr. Diana Cervantes worked in public health practice for over 15 years as an infectious disease epidemiologist and as a public health microbiologist, where she responded to several outbreaks in both acute and long-term care settings. Dr. Cervantes was also the infection prevention manager in a large acute care facility. She is currently an assistant professor and the director of the MPH epidemiology program at the Health Science Center in Fort Worth. Dr. Cervantes is certified in public health, infection control, and is a technologist in molecular biology. She is also a fellow with the Association for Professionals in Infection Control and Epidemiology. Her teaching and research focus include applied epidemiology, infectious disease prevention and control, and public health, gerontology, advocacy, and practice. Hi, Dr. Cervantes. Thank you so much for joining us today.
Oh, thanks so much, Jesse and Nikki, for having me. I'm excited to be on.
We're excited to have you.
Absolutely. I loved reading through this survey. There's a lot of good information in there. So I was hoping that you could start us off by telling the listeners why the MegaSurvey was performed.
Right. So the MegaSurvey was first performed in 2015 and then again in 2020, just to get really a snapshot of what is going on in terms of infection preventionists and the profession. What are the tasks? What are the duties? What are some of the requirements? What are the compensations? So just to get a snapshot of what's going on with the profession.
So I wondered, before we jump into the meat of it, there were a couple of terms in there that I wondered if you did define for the survey participant when they were taking the survey, or if you could define them for us now.
Right.
And the first one is, quote unquote, HAI-related activity as it relates to the job setting.
So in the survey, that was not specifically defined for the survey respondents. So it just asked what percentage of your position is officially dedicated to HAI activity. So that wasn't defined. Of course, HAI is healthcare-associated infections, and that could really run the gamut. It could be as broad as you want it to be.
Okay, so this was kind of up for surveyor discretion, or surveyee discretion as to how they answered that.
That's correct.
Okay, and so I wonder too, when it comes to the infection prevention and control activities, you mention a lot like surveillance, transmission prevention, management and communication, cleaning and sterilization, environment of care, identification of infections, education and research, et cetera. So were those defined, or were those also kind of left up to surveyee, I don't know if that's a word, surveyee interpretation?
Yeah, so whenever the survey was conducted and respondents went through the survey, there were different tasks that were grouped into these headings. So you just talked about, for example, identification of infectious disease process. So that was a large group. That was a group of questions. So there were about 5 questions that were under that heading. So, for example, interpreting a diagnostic and lab report, how to appropriately handle specimens, how to collect, transport, handle specimens. So in that grouping of questions, they were asked, do you perform this work? Do you supervise or train for this work, or do you do both? Do you perform it and also supervise and train? And so because there were so many questions in each of these large headings, we just did an overall percentage on, did they say they either perform the work or supervise and train that type of work?
I see. Okay. So you kind of took their answers and bundled them into your categories as well.
Yeah, exactly.
Okay. That makes sense.
So when we're thinking about these IP related activities, surveillance, I think for many IPs is a bulk of their work. And some of us, I think in the past, Nikki probably has done this, have had paper reports and printouts that we've had to search through in order to do our surveillance. And so as part of the responses, it sounded like that many of the IPs did not have an infection control surveillance software system available to them. Do you think that this had anything to do with the budget for these types of facilities, or do you think they just were not up to date with the technology?
Yeah, it may have to do with budget. So one of the questions that was asked is, what is the dollar amount of your budget in your IP department? And the majority of people said they didn't know. 86% of them overall for the survey respondents. And so it may be budget. I think also one of the things that we focused on specifically in this survey were people that worked in one specific non-acute care setting. Now, the majority of respondents for the overall survey, they stated they worked both acute care and non-acute care settings. So I think when you take out that acute care and you just focus on one specific non-acute care setting, then there are limited resources available to people who are just working in one non-acute care setting.
That's unfortunate. Again, just thinking about the amount of work around some of this surveillance and not having that type of software at your fingertips, which can really be helpful and reduce some of that time spent to make you available to do some of those other IPC activities. So one of the other, as we're talking about sort of defining some of the terms within the survey, high consequent event was mentioned. And I was just wondering if you could talk a little bit about where it says that there was decreased time spent routinely on HAI activities and job functions that resulted in IPs being less prepared during a high consequent event. Tell us a little bit more about that.
Yeah, so when we talk about a high consequence event, that's going to be any type of event that is going to cause increased morbidity, mortality, and it's going to really put a lot of restraints on resources. It's going to strain the structure and the resources in terms of doing your day-to-day functions or just doing the things that we do every day in society. And so that's going to be a high consequence event. And so when we talk about this, decreased time spent routinely on these HAI activities in day-to-day functions, and then therefore being less prepared, it really has to do with, IPs wearing multiple hats and doing so many multiple things. Whenever you have, whenever you're wearing so many hats and you're doing so many different tasks and you're, doing less of your actual job that's supposed to be on those HAI related functions, then whenever you do have these high consequence events that you do have a lot of morbidity and mortality, you're already kind of working on a weakened foundation. So you have to now take on a much heavier burden of work. And now on top of that, you have this high consequence event that you're having to deal with. So I think that whenever IPs aren't able to dedicate their time to what they really should be doing on their day-to-day functions and they're wearing multiple hats, then when a big event happens like the pandemic, then you're really struggling to stay on top of your day-to-day things as well as these things that happen with a high consequence event like we saw with the pandemic.
Oh my gosh, I love that. I love that. I'm going to use that because we talk a lot about, especially in the critical access locations, how we have IPs that have, sometimes 3-4 different hats they're wearing. And we hear about the struggles that, the pressure that they feel that they're not able to manage the infection prevention work as a result of, having all of these other hats they're wearing. So I appreciate that sort of defining that and using that term. That's great.
And in that same area of the paper, it says that there are growing concerns that a singular focus on COVID-19 mitigation strategies might adversely affect the surveillance and prevention of HAIs, et cetera. And I just remember how, there was a singular focus. It occupied our time and our minds so much that I almost feel like IPs felt like all their time needed to be spent on COVID. When they started doing their day-to-day activities, almost felt guilty, like we were, no, we need to be focused on COVID-19 all the time. So that was a stressor for sure.
Absolutely.
Yeah, definitely. Yeah, it's we saw that both in the IP world and the public health world. It's like everything else was put on the back burner and everything was COVID focused, and those things that were sitting in the back burner were just they were getting to a point where they were in a boiling point, right? They just getting overflowing. Yeah. So
starting lots of fires for sure. Yeah. So I wanted to talk a little bit about your findings on region in the paper. So my next question is kind of twofold. I didn't know. So there was statistical significance found for region of residency. And I was wondering what you think that tells us. And in addition to that, were you able to further stratify the annual salary by region? And I just asked because I don't know how cost of living would affect those results. Or what do you think that statistical significance tells us?
Yeah, so there were more respondents from the East as well as the West. And whenever it came down to salaries, of course, the salaries were higher in the West. And I think that cost of living had to do with it. And, one of the things that to me was surprising, I'm from the South, right? I'm from Texas. So to see that, the majority of respondents did come from the East and the West, and there's just really kind of this gap in the South, I think it really does show that I don't know if it's requirements are different or, just the idea of infection prevention in general and the need is different, or maybe people are just going to where those salaries are higher. But there was definitely a gap there noticed in the South compared to, of course, the East and the West.
That's interesting for sure. We talked a little bit about dual roles just now, and how that can impact, people's work. But do we have a sense of how many people that responded to the survey actually held a dual role? And do we know then how much this impacted the time spent on those IP activities?
Yeah, so overall in the survey, there were a little bit more than 2,000 respondents. But if we just really looked at people who reported that they were frontline IPs or IP administrators or directors, about a little more than half, 57%, said that they worked in both, potentially an acute, but also at least one non-acute care setting. So a large proportion of people did mention they worked both, again, at least one non-acute care setting and then maybe potentially an acute care setting. And so they worked multiple settings. And that's what differed in the 2020 survey, MegaSurvey, than the 2015. We allowed people to select more than one location. In the last survey in 2015, people had to choose, what is your primary setting where you perform your job? And in this survey, people were able to select acute care and several different non-acute care settings. So it really does go to show that a lot of people are working both acute care and multiple non-acute care settings. I know, of course, when I worked in an acute care setting, it wasn't unusual for us to say, oh, we're obviously going to, check on the ambulatory care centers that we also had under our license. So that's not really surprising to me. But we did see that compared to the 2015 survey to 2020, there was, of course, that reduction in the time spent on HEI activities. And maybe, again, it's because in this survey, we were able to kind of narrow down on people who, again, in this specific study, just worked one non-acute care setting. So I think being able to tease out the data a little bit like that did show that, that was a potential impact. If you're just working in one non-acute care setting, then your time spent on those HEI related job tasks are lower.
Yeah, that makes a lot of sense to really get to the bottom of that. I imagine if they're only reporting that they're working in an acute care setting, you're sort of missing a lot of data sort of behind the scenes around what's actually happening in the world of infection prevention. And I wonder if also people might respond that the majority of their work is in that acute care setting, because historically it's been acute care is where we have a higher level of concern because of the acuity of the patients and whatnot. So, we didn't direct as much attention necessarily to our other non-acute locations. But so in thinking about, infection preventionists in general and, working in both of these areas, did you happen to determine what types of backgrounds the infection preventionists in these non-acute areas generally came from, like RNs and med techs or microbiologists? Were there, a large number of one or the other, and were there other disciplines that partook in the study as well?
Yeah, so not surprisingly, the majority had a background in nursing, some type of nursing background. I think second to that was laboratory science. So people who had backgrounds in, as you mentioned, medical technology as microbiologists. There were also quite a few that had public health backgrounds. So it kind of ran. It ran from being healthcare. Nursing to also lab science, but I would say in general it was the basic sciences is that what people had backgrounds in.
I will take any opportunity to plug the importance of a multidisciplinary team. So I wonder if you think that the survey highlights a need for a variety of experience and disciplines in the IP world. Are facilities open to looking beyond nursing and micro for IPs?
So I think when we look at these non-acute care settings, because they potentially wear so many hats and they're doing so many different tasks. That's why they're really focusing on, so many people do have a nursing background because they do work both bedside and then they do their IP jobs as well. So they're doing bedside care, they're doing their IP positions. And I think that there is a lot of room and for opportunity and growth in non-acute care settings to have a dedicated IP. And as you start looking at a dedicated IP or a dedicated IP team, then it's great to have somebody who does have that public health background, somebody who's micro, somebody who's nursing, because as we see as the field changes more and more, it's great to have that nursing background, but also to really understand surveillance and understand, all of those basics that when it comes to epi investigation surveillance, it's also really important.
Mm-hmm. Yeah. And you mentioned before, like in the IP world, like, oh, I should go check on my ambulatory centers. So, the study, from what I read, it kind of, if people wore an acute care hat, they were excluded from the study. Is that correct?
Yeah, that's exactly it. So we really wanted to understand what is going on if you just work specifically in one non-acute care setting. So if you worked in long-term care, if you worked ambulatory, if you worked in a psychiatric hospital, what are your resources? What's your background? And I think it was good that in this survey we were able to even see that the majority of participants, almost 60% of them, said they worked in more than one setting. It just goes to show the amount of variety of information and the type of knowledge and skills you have to have as an IP. You have to work so many different types of settings. I mean, there's, you can't compare an acute care to, of course, a long-term care. There's a lot of difference in those settings. But so to be able to say, hey, as an IP, I have to do both things. That's quite a range of knowledge and skills that you have to apply in your tasks.
Yeah, it really does give an insight about the need for IPs in those non-acute healthcare facilities, because like you said, people are wearing so many different hats, and a lot of the acute care facilities are also taking care of non-acute care facilities.
Yeah, no, they are. And again, with regulatory differences, I think, we talked a little bit about the differences between different regions. And I think that makes a big difference. Yeah, there are CMS regulations, but there are also licensing laws that differ by state. And I think they're somewhat more stringent in the East and in the West than they are in the South. And I think that makes a difference as well.
So specifically speaking of the licensure and things like that, I did note that one of the questions that was asked was whether or not the infection preventionists were certified in infection control, and also what their level of education was. What do you think the tendency was for requiring either, a specific degree or certification in infection control?
So in terms of certification infection control, the majority did not require CIC. The question asked, was it required, or was it something that was desired? And I think for the majority of facilities, that's something they desired, but it wasn't a requirement for the position. And we did see, even when we looked at people who were certified, just in general, it was quite low, is about 13%. And so when we look at this certification, we think, okay, what are some of these requirements in terms of education? The majority did say, yes, it was nursing, or they had to have some type of certification, a lab certification, or some other healthcare certification. Those were the most required types of positions.
So, in comparison between a non-acute care setting and an acute care setting, do you think that there was a difference in the non-acute care settings requirement for the CIC? Do you think that was something that was less standard, or do you think it was just, as you mentioned, desirable to have?
So I didn't really look too much into the acute care specifically because again, in this paper, we focused just on a non-acute care. But overall in the survey, I think about 30% of participants said that their facilities did require a CIC. So when we just looked at somebody who worked in one non-acute care setting, it was quite a bit lower, as I mentioned, something about 13%.
So I wonder if we can infer anything from the 2015 and 2020 surveys regarding the need for infection prevention specific degrees or programs.
Yeah, so I think that we definitely need to think about, when we look at looking at this background of, having nursing or public health or microbiology, I think if we're thinking about infection prevention specific degrees or programs, we really need to look at, there is a need, and I think it does need to have a broad variety of different backgrounds to make sure that you are covering that a little bit of nursing, a little bit of public health, and a little bit of micro. I mean, we know, I think, if you've taken the certification test, it does ask you a variety of questions, and that's really what it takes to be an IP. And so, yeah, I think that we do need to have some IP specific degrees and some programs to be able to really cover all of the requirements of being a good IP.
Yeah, because, some people take on the role with certain expectations of what it's going to be like, and it's completely different, myself included. I thought IP would focus more on certain things. I won't, I've been in there a while, so I won't go into my background. But yeah, it helps to have a little more direction, a little more schooling with that. So I agree that's a need. And I wonder, what about key recruitment opportunities? I think that kind of ties into it. I don't know if we can infer anything from the surveys around recruitment opportunities and education and such.
So I think that when we look at the survey response for these non-acute care respondents, the majority of them, 82%, said that they expected to be working in the field of infection prevention control in the next 5 years, although only a third of them said that they were actually satisfied with their compensation. So I think when we're thinking about recruitment opportunities, I think it's really important to maybe focus on some professional advancement and ways to advance you through the profession to help these people who, these professionals who say, yeah, I want to stay, I'm dedicated to this profession. I want to stay here in this profession for the next 5 years. And in order to really help them with increasing their satisfaction, their compensation, that's something to focus on. So as you're thinking about recruitment opportunities, how are you going to help the professional advancement of this person in this position? I think that's going to help with recruitment.
That's great. I think that sounds great. I think professional advancement is always a key to keeping people happy and staying in the field. And especially after 2 years of pandemic and feeling beat down, I think anything we can do to encourage our wonderful infection preventionists to remain in this field, we should be working really hard toward. So last question. If there was a survey now, after 2 years of this COVID-19 pandemic and just 2 years have gone by, which parts of the survey would you expect to see significant changes in the responses?
I think that it's going to have to be time spent on infection prevention control activities. We've heard from a lot of IPs that, as we mentioned even in this podcast, that everything has been so COVID focused that doing those day-to-day activities that had to do with surveillance or other factors, especially education, research, environment of care, those things, unfortunately, I think would have gone down because there was just such a focus on COVID. And again, those things were kind of put in the background, or, something we'll handle later. We'll put a pin in it for now. And so I think that we will see that the time spent on that would have been decreased during the pandemic. And hopefully now that things are starting to sort of level out somewhat, that we're going to see that go back to maybe pre-pandemic levels. But I think that would have been a big change in that.
That's great. And I just want to say, thank you so much. Like Nikki mentioned in the beginning, I think these surveys are fantastic because it does help us get sort of a pulse on what's happening with our colleagues sort of all across the country, and seeing it broken out into those different areas helps us to better understand, what people are facing, or, appreciate more what's going on. So thank you for that.
Thanks so much for having me on. Yeah, that's great.
I definitely think this is going to be very interesting to the readers because there's just a lot of information. It helps support the need for IPs in the acute care setting, too. This just really highlights the need for more resources and focused education, et cetera, just like everything you guys said. It's a great article. So thank you for putting that all together and being with us today. And what would be your biggest takeaway?
I think the biggest takeaway is that we really do need to start focusing more on having IPs that just focus on non-acute care settings. They're very different from acute care settings, and we need to work on those programs or educational programs, but also professional advancement to help IPs get the right resources so that they can provide the care needed in non-acute care settings.
Absolutely. Well, Dr. Cervantes, we can't thank you enough for being here. We look forward to everybody reading this and hearing feedback from everybody. So thanks for coming on.
Well, thanks so much, Jesse and Nikki, for having me. I appreciate it.
Mm-hmm. APIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Research Committee and Pat Stone and Jean Brandt at APIC, and APIC staff Shanina Knighton, Chris Ruiz, Bobby Gulshan, Christine Miller, Kaylee Deaton, and Kelly Lynn Russell. We work in partnership with Human Factor and audio tech Blake Alton. To hear other APIC podcast episodes and to access information about this podcast and the field of infection prevention and control, go to our website at apicscienceintopractice.org. That's AJIC scienceintopractice.org.